This chart compares survival rates of major cancers. This bar, stuck at 13%, is pancreatic cancer. To understand why it's lethal, we must look at how the disease operates. It acts like a biological fortress, protecting itself with three distinct lines of defense. The first line of defense is the stealth barrier. The pancreas sits deep in the abdomen, tucked behind the stomach and liver. It's a highly irritable, angry organ that is notoriously difficult to access or biopsy safely. Because it is so well hidden, patients rarely show early symptoms. By the time a doctor finds the tumor, 88% of cases have already spread beyond the pancreas itself. The second defense is the moat. As the tumor grows, it creates a highly specialized cellular microenvironment around itself. This environment secretes signals that actively put the body's natural immune system to sleep. The third and final defense is the vault door. More than 90% of these tumors are driven by a specific genetic mutation called KRAS. This mutation acts as a permanent growth signal, considered inaccessible to drugs for decades. When we treat this structure with traditional chemotherapy, the drugs act like a blunt battering ram. They simply bounce off these layered defenses. That is exactly why the survival rate has been paralyzed for so long. To defeat the stealth barrier, doctors realize that if they cannot easily see the tumor forming, they have to predict its arrival before it takes hold. Researchers at Harvard Medical School and the University of Copenhagen developed an artificial intelligence algorithm trained on the medical records of 9 million patients from Denmark and the United States. The AI doesn't look for the cancer itself. Instead, it scans for historical patterns in a patient's health codes. For example, it tracks sequences like a diagnosis of gallstones, followed months later by anemia, and calculates the compounding risk over time. Look at this timeline of a patient's medical history. By linking these seemingly unrelated symptoms, the algorithm can identify people at high risk for pancreatic cancer, up to 3 years before an actual diagnosis is normally made. This predictive capability bypasses the stealth barrier entirely. It allows doctors to focus expensive, invasive tests like MRI scans and endoscopic ultrasounds on the right patients, intercepting the cancer before the fortress is even built. Once the cancer is detected, the second challenge is the moat. Doctors must now wake up the patient's immune system to clear the dense immunosuppressive environment surrounding the tumor. One approach comes from Northwestern University, where researchers developed an experimental drug called elraglusib. Rather than poisoning cells directly, elraglusib targets a specific protein called GSK3-beta in the tumor's microenvironment. This action shuts down the tumor's suppressive signals, allowing cancer-fighting immune cells to flood the area. A parallel attack on the microenvironment is being led by BioNTech, utilizing the same mRNA technology developed for vaccines. The mRNA is tailored using genetic material extracted directly from the patient's tumor. It acts as a specific training program, instructing the patient's immune cells to recognize and attack the unique proteins found on their cancer. In clinical trials, adding these microenvironment therapies to standard chemotherapy has shown the ability to double a patient's chance of surviving past 1 year. By reprogramming the microenvironment and training the immune system, doctors no longer fight the cancer alone. They are turning the patient's own biological defenses into the siege engine. That leaves the final, most formidable defense, the vault door of the KRAS genetic mutation. When the KRAS gene mutates, it behaves like a switch stuck in the on position, locking the cancer cells into a state of constant, uncontrollable cell division and growth. A new once-daily pill called daraxonrasib, which recently released Phase 3 clinical trial results, is designed to directly target this exact mutation. The drug daraxonrasib physically binds to the mutated RAS proteins, effectively switching off the cancer's uncontrolled growth signal. This bar chart details clinical data for late-stage patients after prior treatments. Standard chemotherapy yields a median overall survival of 6.7 months. For those taking daraxonrasib, that number jumps to 13.2 months. This single pill doubles their median survival time. By successfully inhibiting the KRAS protein, researchers have stripped the cancer of the primary driver that previously allowed the disease to resist medical intervention. Looking at the broader medical landscape, the results from 2023 to 2026 suggest that the era of relying solely on general chemotherapy is finally ending. AI algorithms catching the disease early, Experimental drugs reprogramming the microenvironment and pills inhibiting the KRAS mutation are not isolated events. They represent a synchronized, multi-front precision assault on the disease's biology. No single cure exists right now, but deploying these highly specific tools together actively shifts the odds of survival in the patient's favor. This shift introduces a critical new requirement for patients. Anyone diagnosed must demand genetic and biomarker testing of their tumor to identify actionable mutations, like KRAS, that these new therapies can target. It also underscores the necessity of participating in clinical trials, which is currently the only way to access these exact therapies and help push the science forward for others. Through the lens of precision medicine, pancreatic cancer is starting to transition from an immediate death sentence toward a disease where outcomes are significantly more influenced by data and targeted intervention.